I want to thank you all for coming out today on this rainy day for Sundays at 2 to hear our speaker, who many of you already know and some are patients of. But before we go further, I'd like to do a few housekeeping things. First of all, the bathrooms up here are in the back and around the corner. There are 2 emergency exits, front and back. Would you please turn off your phones, turn off your watches, so we don't have any interruptions. And we're going to ask that you hold your questions until the end of the presentation. And someone will bring you a microphone so that the question can be heard upstairs, downstairs, and online. Afterwards, we ask you to enjoy some refreshments with us and spend some time. Maybe you'll have some additional questions for Dr. Ellenbogen, but I have promised him time to get home for the Super Bowl. He almost comes without introduction. He's from the Pauli Hart Center at VCU. He is the director of electrophysiology and pacing at MCV. He came on board the faculty in 1985 and was full professorship in 97, is that correct? He's a New York native, although he doesn't have the accent. I never quite understood that. He worked his way slowly south, starting with his undergraduate at Princeton, then went on to medical school and residency at Johns Hopkins, and then down for his fellowship at Duke. A researcher who has studied both the use and new techniques for atrial fib. He's also been very involved in developing and the use of pacemakers, the modes and so forth that are used. And he's prolific in his writings and in medical journals of cardiology. And he also has authored many and spoken both at large universities, Harvard, Yale, just a few of those, and all over the world. So we are very pleased to welcome Dr. Ellenbogen, and I ask you to give him a rounding
Thank you. It's a pleasure to be here today. And I'm going to talk to you about atrial fibrillation, something I've spent probably the last 20 of my 37 years in Virginia working on initially ways to treat atrial fibrillation with pacemakers. There was a brief period of time when there was an atrial defibrillator that we worked with, but particularly interested in new types of drugs to treat atrial fibrillation and ways to prevent stroke and atrial fibrillation. You'll hear a little bit about that today. But the most exciting advances in atrial fibrillation began, in my mind, with some work we started doing in 1998, and you'll hear a lot about that. So today we'll start off with a little bit of information about atrial fibrillation, and then I'll take you through the history of our attempts to treat atrial fibrillation without drugs. So just so we all, even though you've probably heard the term thousands of times, I'm going to go ahead and read you a brief definition of AFib, or atrial fibrillation, written for people and not physicians. It is an arrhythmia. An arrhythmia means it's an abnormal heart rhythm, right? No one is born with atrial fibrillation. People are born in normal sinus rhythm. It means your heart's normal rhythm is out of whack, and because your heart's normal rhythm is out of whack, the blood doesn't move through the chambers in a normal fashion. And that predisposes to the development of congestive heart failure. So congestive heart failure is when your heart doesn't pump enough blood for your body's needs. Blood can also pool inside your heart, in particular in people who have AFib, 95% of the time. It pools in an area of the left atrium called the left atrial appendage and forms clots because of the particular structure of that, and I'll show you a picture of that or two. If one gets stuck or goes to your brain, you have a stroke. About 90 to 95% of the clots that occur in AFib do go to the brain. So an AFib, the top part of your heart, called the atria, there's one on the right, one on the left, squeezes first, and then the bottom part, the ventricles, pump blood either to the lungs or the body. And the timing of these contractions is what moves the blood. When you have AFib, the electrical signals that control this process are off kilter. Instead of working together, the atria do their own thing. In other words, they fibrillate and don't really contribute what they're supposed to do, which is perform or act like a booster pump for the rest of the body. And this is just a picture of the heart. We always talk about the heart as having its own intrinsic or normal pacemaker. In talking about pacemakers, that'd be another hour of your time. We can talk about that some other time. But here's the sinus node. It's the heart's normal pacemaker. It is a richly innervated structure by both blood vessels and nerves. And it is your pacemaker. And from this pacemaker, electricity goes to the heart, both the right and left atrium. And what you have to remember is electricity comes first. And once there's electrical activation, then there's mechanical activation. So if the electrical activation is abnormal, the mechanical activation could be messed up. This just shows you how the electrical signals are carried to the ventricle, the bottom chamber of the heart. Now, this is an absolutely fascinating disease because one of the realizations over the last 10 or 20 years has been that atrial fibrillation is incredibly common. And it's particularly common and related to people getting older. That's just a fact, not making a judgment or anything, but a lot of times people will come to me and say, hey, I'm 72 years old, I'm 5'10", I weigh 165 pounds, I go to the gym every day, why do I have AFib? Well, unfortunately, in many people, it just happens as we get older. Even if you don't have sleep apnea, even if you don't have diabetes, even if you don't have hypertension, you can just develop AFib. We used to call it idiopathic AFib. We don't even call it that anymore because there's so many people who have it. This shows you the world's population. You can see there are a lot of old people in Russia and in Eastern Europe, less so in Western Europe, and in the United States, okay, and Australia, and I guess Argentina. And you can see in the US, we're not quite there. Only 12 to 20% of people are over the age of 60. But anyway, as the population gets older, then now you look at 2030 and you see where the population is going to be over 60. And the problem is that this is a population of the aging population. This is a medical problem in the aging population because the incidence increases with age. So we're going to be facing an epidemic in terms of people who have AFib. By 2030, 20% of the US population, 70 million people, will be 65 or older. And we sometimes tell people after about 75 or so, almost 10% of the population has or will have AFib. That's amazing. Here you can see a graph based on some data, and you see how the incidence of AFib increases with age. These are just different projections of where we may be. Looks like we'll be closer to here, but this is a huge number, huge increase in the number of patients. When you think, okay, we're in 2024, we're right over here. And in 20 years or so, or 25 years or so, the number of people with AFib will double. That to me, that obviously is a real problem. Now, AFib is one of those diseases that affects men and women almost equally. And again, of course, more women attain an older age than men, but you can see here, this is data from the Framingham Heart Study, which was a population-based study in Massachusetts where they followed all the patients very closely. You see the number of people who end up with AFib, and it's very, very similar in women and men. And it's probably almost identical because AFib does have something to do with body size. And women in general tend to be less tall and less heavy than men. But if you include that, then the incidences are almost identical. So, as I said, the number of patients with AFib is going to grow exponentially or more than linearly, and AF is associated with about a 5 or 5.5, 5.6 increase in the risk of stroke. So this is a problem, particularly in older patients or those, especially those with a history of prior stroke or TIA. We think up to 15 to 20% of strokes are caused by atrial fibrillation. And not only is there a high incidence of stroke in AFib, there's a high incidence of clinically silent strokes in AFib, there's a high incidence of recurrent strokes in AFib, but that associated with that is a high mortality, and associated with that is people who have strokes with AFib, they tend to be much more disabling than strokes to carotid artery blockages or strokes due to hypertension. On top of that, AFib is associated with a 2 or so fold increase in the risk of dementia, and all types of dementia, not just Alzheimer's. And we think a lot of the mechanism for that is related to what AFib does to blood flow to the brain. And that's a complicated area of research ongoing now, and we can talk more about that later. Well, what has been transformational is the ability to record an electrocardiogram, because AFib is diagnosed by an EKG. This, I thought you'd have a kick looking at this. This is the first EKG machine. Okay? It was developed in 1901 by a Dutch pioneering physician named Einthoven, and this is him. In those days, physicians tended to develop diagnostic and testing things they used to develop on themselves, right? There wasn't a lot of clinical research, but he's recording an EKG on himself. Also, the first cardiac catheterization. Again, someone at the Cleveland Clinic did that on themselves. Now we have this amazing technology, which I have to admit, I do not directly own any Apple stock. I do own mutual funds, and I'm sure Apple is one of the, just by the nature, is part of my own earnings, but owning. But this is an amazing technology, healthcare, smart watches, particularly for cardiologists. I expect very, very soon we'll be able to get some sort of measurement that's similar to blood pressure, but the ability to record an EKG, and now these watches will tell you how much AFib you actually have. So they're very, very useful for us as physicians to monitor patients. So the initial work in AFib was done early in my cardiology training in 1980 to 86, when I was training in medicine and cardiology. A surgeon from, I guess, I'm not quite sure where he was originally from, but ended up at Washington University, named James Cox, Jimmy Cox. He was at Duke actually for a while, but then left before I got there, and then went to Washington University. Developed this amazing operation called the Maze surgical operation. It was a huge operation. It involved open heart surgery. It involved cardiopulmonary bypass. It involved a 10 to 15% chance of bleeding and having to go back to the OR to deal with bleeding. Another 15% chance they would destroy your sinus node, so you need a pacemaker. But at the end of the day, it was remarkably effective for preventing AFib and for preventing strokes, because they literally took both the right and left atria, made numerous surgical incisions, and then sewed everything back together. As you can see here in this slide, you can see there are multiple incisions. I don't think it's critical to go through them all. 1, 2, 3, there are several here. And it was basically proof of concept, right? It showed that AFib could be treated by surgery, and that AFib could be, I've never used the word cured, because actually we were some of the first people, I did some of the first cases of people who had the surgical procedure, and then came back 15 years later with other arrhythmias that had to be cured by catheter ablation. So it was not a cure, but it showed that people could have a surgical procedure who were in permanent, so-called permanent AFib, and then can live for 10, 15, maybe even 20 years before their AFib came back. So Albert Einstein said, actually in 1911. Nature did not deem it her business to make the discovery of her laws easy for us. And that certainly is true in AFib. So we've been involved in treating AFib for a while by using invasive methods to map the atria, the part of the heart where AFib comes from, and test the paradigm that it might be possible to treat some patients with AFib, particularly if we treated them early enough, without ablating their entire atria. So the mechanistic target in the beginning of the treatment of AFib, which we got involved in 1998, we actually thought this. We actually thought that perhaps, so this, I'm going to go back actually in a second. We actually thought we're going to be really smart, and we developed catheters that allowed us to do what the surgeons did. So it allowed us to make an ablation from the superior vena cava in the right atrium to the inferior vena cava, and a bunch of ablations in the left atrium. And this is what it looked like in the EP lab. We had these long catheters, and we pioneered this in 1998 with the folks at Johns Hopkins and the University of Alabama at Birmingham. So we figured out if we could just do this with a catheter, and these were the catheters we used, and these are the different views, and you can see the catheter had multiple electrodes and it butted on the pulmonary veins. And one of the things we figured out is, the X-ray is a very unuseful tool to depend upon to know where your catheter was in AFib, where your catheter was in the heart when you were ablating AFib. So we teamed up, this was just amazing, we figured out that if you could put a catheter through the vein into the right atrium and use ultrasound technology, using crystals that could shoot sound waves in the heart, because your catheter is inside the heart. So you just have to use ultrasound that doesn't have to go that far. You could take enough images, almost like a slice of pizza. If you took enough images, enough slices, you could mathematically reconstruct them. And you could get a 3D picture of the heart, or at least a good 2D picture of the heart. And that was one of the key technological advances that everyone everywhere uses now. So that was pretty exciting. And then we benefited while we were doing this protocol. And there's one person here whose husband was one of the first patients to have catheter ablation. This was 1998, and people were not even ablating AFib. They thought we were crazy. But because of this linear ablation, which we developed, somebody else, a group in Bordeaux, France, took that and realized this just serendipitously. They saw several patients who had frequent extra beats called premature atrial contractions, and they noticed they would trigger AFib. And they were smart enough to realize that, but take that one step past what we were doing, and then they mapped those triggers, which shown here, the triggers that cause AFib, and they said, isn't this odd that all of the triggers, or 85% actually, of the triggers come from near the pulmonary veins. And that was one of the key observations which stemmed from research which we did with Hopkins and UAB and other people did over the world that led to what we do now, which I'll talk to you a little bit more about. Show you some pictures of. So now, where are we? It's 2024. It's amazing. We have a consensus that triggers are critical, particularly early on in the course of this disease, that the triggers almost always come from near the pulmonary veins, although they can come from around the pulmonary veins, so they don't have to always be in here. They can be out here a little bit. And if we can ablate around the pulmonary veins, we essentially create a moat where these triggers cannot escape and cause AFib. Now, there are also some drivers, and that's a part of it we haven't quite figured out yet. Hopefully we will pretty soon. And so what we do when we do catheter ablation of AFib, and this, in the beginning, when we started doing this, as I said, in 1998, we did a couple a month. And then now we do 6 a day. We have a waiting list of 3 or 4 months. Everybody who has AFib wants that. And I hope you're watching the video. Let's see if we can do that again. So the catheter, what we did, it goes point by point by point. These are the veins. This is the vein, this is the vein, this is the vein, this is the vein. See how these contiguous lesions are made with radiofrequency ablation, so the triggers cannot cause AFib. This is viewing the heart as if I'm standing like this, okay? So it's not turned around facing you, but you're looking at the back of the patient. That's one of the amazing things about computers. We can actually turn this around while we're moving the catheter around. Now, in about 2010, I realized that anything that democratized the procedure, and by democratized, I mean made it easier for everybody to copy and do at a reasonable level without the level of skill that we were used to, because we had already done about 500 of these, would be a good thing. And we began to do studies with the cryoballoon. There are a lot of different, what we call single shot ablation catheters. Single shot's pretty good. It's especially good in older people because it makes the procedure simple, easy, and effective. I mean, I've ablated at least 20 or 30 people who are over age 85. So you want to have something that's very simple and very easy to do, and that you can get in and out of Dodge without getting caught. And so really all you need is a wire that goes down the pulmonary vein, and then this blows up to 28. We have adjustable balloons that can blow up to 31 millimeters. And then inside the balloon are jets of nitrogen. And those jets shoot out around the circumference of the balloon. And when there's a phase change, they basically freeze. They freeze the area around or outside the vein and isolate the veins and are remarkably effective. They're remarkably effective because if you monitor somebody with AFib for 6 months or a year, and they can do that in Canada because they have a long waiting list for AF ablation, and then you do an AF ablation, you wait a year later, and on average patients have 98% less AFib. So these are all very effective, and we use mostly cryoballoon. There's some new technologies that are a little bit safer, but nothing really is more effective than an RF catheter or cryoballoon. The newer technologies have not yet been proven to be more effective, but probably a little bit safer. We've also been involved from a very early time. This is a paper we published now about 14, 15 years ago with minimally invasive surgical ablation. This is the amazing thing about catheter ablation of AFib. You can see here the person was in AFib 100% of the time, 100%. Then they had their procedure, 0 episodes of AFib. So it's a very, very effective procedure in many patients. Unfortunately, not every patient. In a desire to find a better mousetrap, we did some work with a group from California that developed this brand new mapping technology called firm mapping. And there were only a small number of centers in the country that were studying this, but we were one of the first 5 to take this on. And this was about now 10 years ago. And somebody made this slide for me at VCU. Anyway, the thought was that what happens in AFib is not just some area, the heart goes crazy and starts firing at 300, 400, 500 beats a minute, but that it was actually a rotor spinning around in the atrium, and that you didn't just have to ablate the triggers, but you had to find the areas where the rotors were. And it's even more complicated if you just watch this again and again. And watch this movie play, which we'll go back and have it play. You can see the rotor rotating, but it needs a hinge. It needs something to stabilize it. And so we have to stabilize it there, and you can see that the results using this particular rotor mapping computer program were very good. And we, of course, but it did involve extra work. It involved the work of putting this special spline catheter in the heart, and you had to move it around to different parts of the heart, and you got these raw maps, which a computer, let's see, I hope that's going to play. I guess it won't play. A computer would have to analyze, and basically it would track the rotor and show you where the critical areas the rotor tracked to. Then you'd have to take that mapping catheter out and put an ablation catheter in and go to that spot and see what you could do. Now, this is just a recording from a patient's heart. And the reason why I show you this recording is, if you look at this, you will appreciate the following. So on top are some surface EKGs, 3 surface EKGs. This is an electrical recording from the poles on the catheter in the heart that we're going to use to ablate. We're going to use radio frequency energy to destroy the areas where we think AFib is coming from. This is just a catheter we used for anatomy. And this was a special type of catheter. And I want you to see how complicated and how rapid the signals are. This signal inside the vein is occurring at 100 milliseconds. It's about 100 milliseconds, give or take 10 or 15 milliseconds. That means that area is being electrically activated 600 times a minute. And if you look at this, you'll say, hey, that's pretty constant, I get that. But where would you say the activation is here? Is it here or is it here? Is it here or is it here? And look how fractionated this signal is. It almost looks more continuous, and then it's not, and then there's no signal here. So the point is, the electrical activation is changing. You have multiple recordings from inside the heart. This is a very complicated problem, a problem that only computers can solve. And as I said, in order to solve that problem, we need incredible recording fidelity and incredible computer power. And it can't be computer power where you send the signals to some lab somewhere, a couple hours away. Of course, signals go, right? You can speak to your kids in Washington State or California. There's no lag between the time you ask them how they are and they answer. So we can send signals there pretty quickly, but they have to be processed, even if they're complex signals. And to make this work, it has to be online processing, okay? So, for example, here's a new type of catheter. This is developed by a company called Afera. May actually be approved sometime next year. And you can see it has a lumen, so it's bathed in the bloodstream, in the blood pool, and it can be moved around the heart. It has multiple electrodes, multiple thermocouples, so it can quickly map 10,000 points in the heart and analyze that and give you a map, and then you could ablate through that. So, okay, but maybe the Lion should not be doing that. Maybe there's a better approach to the problem. So we began working with this group out of Vermont who has spent the last 10 to 15 years working on this problem. Small company, small group, one doctor who had this vision of being able to map AFib better than anyone else. And so this is a map here of normal rhythm. And you can see how rapidly things happen. And this is a map of AFib. And you can see it's not repetitive. and the colors are coming in different ways, different angles, different directions. And we don't have the tech, and they realized early on that one of the things we're doing with AFib ablation these days is we're building bigger and better guns. So we can ablate more of the left atrium, but it's empiric. We don't have the maps yet that can guide us. So if you ablate more, patients do better. That may be true, but our goal, my goal has always been, I want to ablate the least to get the best result and not the most to get the best result. So that's what AFib looks like if you try to map it. If you try to map it with just 3 wires, you only see small areas of activation, and you can see how blurry these are. So instead of using that, we're going to use, to visualize this, we want to use a different type of tool. The problem with current technology is it tries to produce, we don't know what to do with those complex signals. For example, is this a signal? Is this a signal? Is that a signal? And what about this thing here? And are these 3 or 4 more? Where are the signals? You know, there's this thing in computers called GIGO, garbage in, garbage out. So the critical thing is to find a way to record accurate signals. And if you don't have enough electrodes, and you don't have the right size electrodes, then you can't adequately record electrical signals from the human heart. So this is what a standard ablation catheter looks like. This is the real size, okay? This is the size. It's 4 millimeters, okay? That's a 4 millimeter electrode. Actually, some companies it's 3.5 millimeters, but let's imagine it's 3.5, 4 millimeters, whatever, okay? This is what we're working with, 0.05 millimeters, okay? So it is 100 times smaller electrodes, 100 times smaller electrodes. And this is a dime, and this is what the mapping catheter looked like. So we decided to get involved with this a number of years ago, and we began by mapping patients who were going to the operating room for bypass surgery or going to get a valve, and we spent a couple minutes while they were there, and we put this on the heart, and we started mapping their AFib. And when we mapped it, we were able to get these amazing signals and make these maps. And for the first time, and we've been asked not to publish this because the person who's developing the system wants to test the hypothesis that not only can we map AFib, but we can map it to figure out where to ablate it, like at 1 or 2 points. And this work is actually, the feasibility studies are being done in Bordeaux, France, and Prague, the Czech Republic. They will be beginning in about 6 months, and we'll see if all this preclinical work and human work will result in our ability not to ablate the entire area, but to be able to find the critical spots for AFib that need to be ablated in order to treat AFib. Now, I'm going to shift gears a little bit. We're still going to talk about AFib, but I want to tell you about the left atrial appendage. It's a part of the left atrium that we're not 100% sure what it does other than allows us to form clots. This is a picture of the left atrial appendage here, and it's a large blind pouch which has, you see the trabeculations? It has these trabeculations here. I call it, I explain to patients, it's the difference between a potato chip and ridges. You know, those potato chips have ridges. That's the difference, okay? If you have a smooth left atrium, like most of the left atrium, clots don't form there, it's smooth. But if you have this blind pouch with these ugly trabeculations, that's where clots can form. And that is a problem because when you go back and look at studies, mostly autopsy studies, but also transesophageal echoes, where they have an echo probe down in the esophagus, all of a sudden they can find clots. and you can see over 90% of them are in the left atrial appendage. So, in the beginning, many, many years ago, the surgeons actually realized this. And beginning in 1949, they would try to cut off the left atrial appendage, and this is what it would look like. They amputated the left atrial appendage and epicardially oversewed the left atrial appendage stump. Or they endocardially excluded the orifice of the left atrial appendage if they're going to repair the mitral valve. And then a bunch of inventors developed this percutaneous left atrial appendage device. One of the leaders in developing is David Holmes from the Mayo Clinic, who's now retired to write poetry. But anyway, and they figured out a way to implant these. These are the two leading devices, the Watchman, which has been implanted in over 350,000 patients, and the Amulet, which has probably been implanted in, 10 or 20,000 patients. And then the devices were improved in design. And if you think about it, drugs that we use to treat patients with AFib, like Xarelto and Eliquis, are really expensive. So if you happen to be living in China or another country where they don't have a lot of money to spend on drugs, developing left atrial appendage occlusion devices is really critical. And about half of the companies that have new left atrial appendage devices are from China, because they have over 1 billion people, and they have a problem that we have. They have a very elderly population, far more so in China than in the US. And so they have a lot of people with AFib, and they have a lot of people who can't afford to buy Eliquis. So they need another solution. And you could say, well, they can all buy warfarin because that only costs $1 a month, except they have to check INRs, and they don't have the infrastructure to be checking patients' INRs every month. So there are ways to occlude the left atrial appendage to prevent strokes. And this is the animation.
Nearly 1 out of 3 AFib patients will have a stroke. But why are they more likely to have a stroke than people without AFib? For patients with AFib, over 90% of stroke-causing clots that originate in the heart are formed in a structure called the left atrial appendage, or LAA. Everyone has a left atrial appendage. It is a small pouch that sits off of the left side of your heart. AFib may cause the blood being pumped through your heart to pool in the LAA, where it gets stuck and can form a clot. If that clot escapes and gets into your circulatory system, it can block the blood supply to the brain and may cause a stroke. Today, a number of treatments are available to reduce this risk of stroke. Blood thinners such as warfarin or Coumadin have been available for more than 50 years. But blood thinners affect the entire body and may not be well tolerated by everyone. They may have side effects like bruising, nosebleeds, gastrointestinal bleeding, or, more importantly, if the dosage is not properly maintained, an increased risk of hemorrhagic strokes. Plus, some blood thinners like warfarin require going to a clinic for INR checks and may incur out-of-pocket expenses. But there is a new treatment option that eliminates the need for long-term INR checks and the need to take daily prescription blood thinners. The Watchman device is an implant-based alternative to blood thinners such as warfarin. The Watchman implant is designed to permanently seal off the LAA, where blood clots can form. The Watchman implant is about the size of a quarter. The implant does not require open heart surgery, and the device cannot be seen outside of the body. As in a stent procedure, your doctor will guide the Watchman implant via a catheter through a vein in your upper leg and into the left side of your heart. Once there, your doctor will release the implant to seal off your left atrial appendage. The whole procedure typically takes less than 1 hour. You would then need to stay in the hospital overnight, and recovery typically takes about 24 hours. Over time, heart tissue will grow over the Watchman implant, and the LAA will be permanently sealed off. In most cases, patients were able to discontinue blood thinners 45 days after their implant. The Watchman implant offers patients with AFib a potentially life-changing stroke risk treatment option, which could free you from the burden of long-term warfarin therapy forever.
So we obviously started implanting this device a while ago. Now, in 2024, let's say there are 20 million people with AFib, and 95% of those people don't have AFib due to mitral stenosis. Probably 99% don't. And those who are at high risk for stroke are about 75% of the patients. We can put these devices in patients who can't tolerate oral anticoagulant by strict criteria, or about 1/3 of patients at some point in time will have bleeding, or they develop a neurologic problem where they fall or the gait is unsteady and there's concern about falling, so they have a meaningful reason to seek an alternative. But most people, 60-65% of people, can take their Eliquis without any problems. The Watchman is indicated only in these two groups of patients. That's what have been studied in clinical trials. Now, I am co-PI with somebody from Columbia. This is an international study of 3,000 patients, and we have about 2 more years until we get the results. This is a randomized clinical trial, randomized, meaning that these are people who are randomized to either get Eliquis or Xarelto versus a Watchman, and then they get short-term blood thinner for about 4 months, then they're just on a baby aspirin. And so the results of this trial, clinical trial, will help us figure out whether left atrial appendage occlusion devices are just for people who can't take blood thinners or for everyone. And I want to just stop here and thank all the people who I've had the amazing opportunity to work with and do all this work with over the years, over the last 37 years since I've been here. And then I'll be glad to answer any questions. Yes?
You have to stop the heart.
No, we do it in a beating heart. It's a very gentle device, and we're actually into the 3rd generation of devices. So this newest generation has a coating that prevents things from sticking to it.
Could you repeat
I'm sorry, the question was, I'll try to remember that. The question was, do you have to stop the heart to release the Watchman or to implant it? And the answer is no, we do it in the beating heart. And I was just saying the device we implant now is a 3rd generation device. It's very gentle, and this latest generation just became available. Just became available in January, something or other, and we should be implanting it in the next week or 2, but it has a coating or covering. We're going to make sure whoever asks the question has a microphone so everyone can hear. Okay.
I can ask it. Does the Watchman have any moving parts?
The question is, does the Watchman have any moving parts? And the answer is no.
If clots are captured in the Watchman, is there a possibility that they could accumulate, clots could accumulate in that area?
That is probably one of the most common questions people ask. And they say, well, what happens if there's a clot inside the left atrial appendage? I don't think that anyone knows for sure what happens in the left atrial appendage when it's occluded like the Watchman does or like the amulet does. But in general, we keep people on blood thinners for about 3 or 4 months. Then we do a special a CAT scan essentially, and we use special software to make sure it's sealed off. So it's, if your question is, does it stay sealed off? As far as we know, yes. I suspect that there are some people who have a bunch of clots there and remain there, but blood can't get in through there, so it's not like more blood can get in there behind there and clot off.
So this is permanent and does not have to ever be replaced, correct?
The Watchman the question is it permanent? Yes, it's permanent, never has to be replaced.
I would like to know about ablations. If you have had a couple of ablations and you have a pacemaker put on in, and you still suffer with atrial fibrillation, can you do another ablation after you have had a pacemaker in?
It depends. The question is, can you do more ablations if in somebody who's already had 1 or 2 ablations and now has a pacemaker? It sort of depends on a number of factors. So if a patient has AFib and they've had a couple of ablations and they continue to have AFib, they may get a pacemaker because, one, people who have AFib often have electrical disturbances of conduction where they have a slow heart rate and need a pacemaker, or they may have what we call tachybrady, where their heart rate is fast in AFib but slow in normal rhythm, and they can't get any more drugs without a pacemaker. Or they may have AFib and the doctor may have said, we've done enough ablation, we're going to put a pacemaker in, but then ablate your conduction system so the pacemaker will control your heart rate and prevent it from going fast, and you won't have to take all these drugs to slow it down. So it depends which one of those 3 you are.
But my question was, after you have had all the procedures and the pacemaker and the ablations prior, but you still suffer with atrial fibrillation, can you put still an ablation after you have had a pacemaker?
Yes, you can do. We do plenty of ablations. People already have pacemakers.
Okay.
Just have to be a little bit extra careful to make sure catheters don't pull any of the wires out of the area they're in. But that's not a big deal. We do it if people have pacemakers and people have pacemaker defibrillators.
I have blisters on the top of my feet, and we've tried everything in the world to figure out what is causing them and can they be cured. Could this be something to do with circulation and with the procedure that you're talking about?
Well, the AFib is an electrical problem, and if you have some sort of ulcers on your feet or whatever, that would be a blood flow problem, most likely arterial, but could also be venous. So I don't think AFib has anything to do with blisters, but it would be a totally different look with ultrasound to look at blood flow.
What would you look for?
You look for decreased blood flow in the arteries in your legs, or decreased problems with venous return.
I understand the Watchman kind of blocks off that part of the heart so that the blood doesn't clot there. How does that relate to getting rid of the AFib though?
It does not have any impact on getting rid of AFib. It is purely for patients who can't take blood thinners, so they don't have a stroke, is to protect the brain, which is the number 1 commandment when you deal with people with AFib at all times. You want to protect the brain.
I have a very simple-minded question. What is the part that gets blocked off? What does it do when it's in a normal functioning heart? Or is it an unknown?
Yeah, that's an important question, a good question. The question is, you're blocking off the left atrial appendage, so what was it supposed to do? Well, the left atrial appendage is a reservoir. Part of the left atrium has primarily a reservoir function, and when you get rid of the left atrial appendage, exclude it by mechanically excluding blood from getting in there, then there can't be blood that pools in there during AFib and by passive flow gets to the left ventricle. So it makes the left atrium a little bit less compliant, but that's all. And remember, when you have open heart surgery, the surgeon will also often clip off the left atrial appendage. And so, the surgeons routinely remove it when you do open heart surgery. Sometimes people semi-jokingly refer to it as the appendix of the heart. It has some purpose, don't get me wrong, but its purpose compared to that of causing strokes, which is a huge problem for patients with AFib.
So what are
the primary markers for an intolerance to the blood thinners?
Well, the question was, what are the primary markers of intolerance to blood thinners? They are primary, every patient is different. I had a patient just come into my office, and sometimes this patient was intolerant to Eliquis. It made him tremendously fatigued. And, people, the main one, 95% of the time when people have a problem, it's bleeding. It's bleeding, or fear of bleeding, or fear of falling. So those are the main reasons why people don't or can't take long-term blood thinners. But various people have various intolerances to individual drugs. Trish.
So if I have a patient who's had open heart surgery, and now, like a long time ago, I didn't know he did it, but now they're in AFib, can I find, obviously I'm putting them on something first, but then can I find out if they've had that?
Yes, so in anyone who's referred to me for left atrial appendage occlusion, and if they have a history of open heart surgery, one of the first things I do is a pre-procedural CTA. I generally don't do them because I am somewhat of a minimalist. I do the least amount of tests on patients because I think show me the tests they absolutely need. So there are some physicians who do a transesophageal echocardiogram on every single patient as an AFib ablation, and then they have a complication, and then it's like, well, why did you do it anyway? You don't really need to do that test. So some people say, well, you should do a CTA on everyone who's getting a left atrial appendage occlusion. I say no, because it doesn't in a major way affect my ability to put a Watchman in. I can figure out while I'm doing the procedure almost everything I would have learned from a CTA, except I think in patients who've had open heart surgery, because 20% of the time I'll say I have bad news and good news. The bad news is for me, I won't be able to do a procedure on you. The good news is for you, you don't need the procedure, and you don't need to be on blood thinner. So yeah, yes, you can do a CTA, and you need special software, and it can't just be a regular CTA. You have to go to a place where they have a special protocol for people to look at their left atrial appendage.
Can I order that through VCU without seeing you first?
Yes, of course.
Okay, great. Thank
Yes.
you.
Question. If you have a Watchman procedure, do you also need to have the ablation?
Well, that's a very good question. Let me repeat the question. The question is, does everyone who has a Watchman procedure need to have an AFib ablation? And the answer to that is, of course not, in the sense that some people are highly symptomatic from their AFib. Some people, and those people need an ablation. Most of those patients can take blood thinners. The Watchman is really for people who can take blood thinners long term. I mean, maybe they'll take them for a couple months or 6 months, whatever, but they're just having problems tolerating them, or they have a job, or their hobby is woodworking, or metallurgy, whatever. But many people have both, but some patients primarily, I see a lot of people in their 80s who have AFib. They've had AFib for years and years, and the AFib has no effect, doesn't bother them. They're able to walk and do other physical activities, but they can't take blood thinners. So those people only need the Watchman. Does that make sense?
Yes, I have a couple of questions. One, partly answered by what you just said, except that in the beginning, didn't you indicate that there are other concerns with AFib besides stroke?
Yes, there are other concerns with people with AFib besides stroke, and those are the effects of AFib on cognitive function over long term. But in particular, people have been in AFib for many years, just can't get them back into rhythm. There's a saying, AFib begets AFib. The longer a patient's been in AFib, the more their biology changes. If people have been in AFib for long periods of time, their left atria enlarge. They get very, very large. so that catheter ablation is relatively ineffective or completely ineffective. And in fact, even surgical ablation is ineffective. So, somebody comes to me and they've been in AFib for a long time, that bird has flown. They may only want to deal with left atrial blood thinning. As people get older, we always have to think of the risk-benefit of any procedure. So if somebody's 87 or 88 years old and they're not that symptomatic in AFib, I'm not going to push them to have an ablation and they say, I can't take my blood thinner. So you just have to, those are all general comments, and medicine is practiced according to the patient who sits in front of you. If a 65-year-old comes to me and says, hey, I feel pretty good, I go kayaking and go bike riding, and I just developed AFib, I would argue that patient, even if they're minimally symptomatic or asymptomatic, should have an AFib ablation because they may not have AFib again for 10 or 12 years. And that's probably the best protection against a stroke. But, if they're 85 and they're asymptomatic, I would treat them differently. And that's just because everything has different benefits and risks.
Well, then the next part of the question is, you were talking about some new procedures that you're studying. Would you recommend that people just wait as long as they can to wait for better procedures?
Well, the question about always waiting, it comes up all the time. We try to get some things, if it were the matter of, hey, you can wait 2 months or 3 months or 6 months and we're sure we can get this new procedure to you, then some patients will tell them that. But most people, we want to do what they need to have done and not postpone it very long, because in particular, as I said, AFib begets more AFib. We don't like to, the longer you leave people in AFib, the less chance you have of being able to get them out of it sometime in the future.
I have one more question. If you have had the ablations and you have the pacemaker and you are under them and amiodarone and all these other good medicines, but you still run all of a sudden atrial fibrillation, you have episodes where you can run 140 and on your cardiac and on your whatever, the oximeter, whatever you call it. How dangerous is it? What can you really do for that?
It just depends how much of it you have and how much has been tried before that. I think having a heart rate of 140 beats a minute for 15 minutes is probably uncomfortable, but not horrible.
It's not horrible.
But having it for, 2 or 3 days would be a bad thing. And, the longer you're in AFib, if your heart's going that fast, the more damage you can do to your heart muscle. Obviously, most of it's reversible, but you wouldn't want to leave your heart at 140 beats a minute for any long period of time.
Then you would be a good candidate for another ablation.
Or something, yeah.
Okay.
I mean, there are multiple options without knowing all the details. Yes.
You haven't mentioned any medications, you just mentioned the ablation. What about somebody who's been on medication?
So I did say, I haven't mentioned any medicines because there really are not a lot of new medicines for prevention of AFib. I'm not quite sure why that is. There's all sorts of studies going on primarily in Europe, but nothing very exciting here. The only thing that's exciting is a new class of blood thinners called factor 11 inhibitors, found serendipitously by using the UK, United Kingdom biobank, where they store DNA from, I don't know, tens of thousands, maybe hundreds of thousands of people, and noted people who have natural mutations in their factor 11 molecule have a lower rate of stroke. So it's been studied here. There are some exciting clinical trials. There are different molecules. One you self-inject once a month instead of taking a pill every day or every week, or every day or twice a day. One of the drugs looks, some of the data looks good, some of it doesn't look good. We'll just have to see how it all plays out over the next 5 years, but it's a really active area of research, a new class of blood thinners.
So
Thank you.
So Dr. Ellenbogen is going to stay for a few minutes, and we have some treats for you in the back, some refreshments. Please join us, join him. Thank you so much, Doctor.
Okay.